I couldn't see the cords, and then the saturation started falling.
The patient is asleep, the surgical team is ready, and the monitor shows a perfectly stable heart rate and 100% oxygen saturation for an elective procedure. This is a middle-aged man scheduled for routine head and neck surgery. Before entering the operating room, he was comfortable and breathing normally without any signs of distress. A standard preoperative airway assessment showed an acceptable mouth opening and a reassuring Malampati score. That single question forces the anesthesiologist to answer 3 sequential points before induction. How difficult might intubation be? If intubation fails, can I ventilate with a mask? And if mask ventilation fails, can I rescue the airway? A comprehensive airway assessment is a predictive diagnostic model for unseen anatomical failure points, rather than a simple checklist of visible facial traits. The induction sequence began normally, starting with careful and successful pre-oxygenation. General anesthesia was administered. The patient lost consciousness, and respiratory apnea set in. Looking at the monitor data, we see a perfectly regular capnography waveform, moving in tandem with a flat, stable oxygen saturation line at 100%. Initial bag mask ventilation was highly effective. This often leads to an assumption of easy intubation, a conclusion that ignores the different physics at play. Those are entirely separate mechanical problems. Maintaining upper airway patency via mask relies on different anatomical physics than establishing the precise geometric alignment required to pass a laryngeal tube. The reassuring physiological data gives the surgical team a false sense of security, causing them to underestimate the difficulty of placing the definitive airway. The most dangerous transition in the operating room occurs right here, when a routine induction forces an unexpected change in strategy while the patient is fully apneic. The clinician executed the first direct laryngoscopy attempt, displacing the tongue to view the vocal cords. Instead of textbook anatomy, they encountered a mechanical failure. The internal landmarks were completely unrecognizable, and the glottic opening was obscured. The immediate clinical reflex is to adjust external laryngeal manipulation on the neck and slightly alter the blade angle to force a view. Notice the physical strain in the operator's grip. This represents a dangerous moment of fixation, repeating the exact physical maneuver with increasing force without changing tactics. The Difficult Airway Society algorithms strictly prohibit unmodified, repeated intubation attempts. A failed first attempt provides diagnostic data. It reveals specific geometric incompatibilities inside the patient's airway that must be actively addressed before trying again. If nothing changes endoscopies, the operator is actively compounding tissue trauma rather than solving the anatomical puzzle. The team transitioned to their second strategy, deploying a video laryngoscope. The camera bypassed the physical obstruction, successfully visualizing the laryngeal structures on the screen and bringing a brief moment of relief to the room. The blue line shows a clear visual line of sight from the lens to the glottis. The red line shows the physical trajectory for the tube, which is blocked. Slicing it reveals an acute geometric angle impinging directly against the anterior tracheal wall, physically preventing delivery. A clear screen image encourages the operator to persist with the attempt, even as the tube meets physical resistance. These failed delivery attempts carry a rapid physiological cost. The friction causes mucosal bleeding, reactionary swelling, and worsening anatomical distortion. Advanced visual technology can actually extend the duration of a dangerous attempt if the operator confuses a clear screen view with physical tube delivery. The clinician withdrew the video laryngoscope and urgently attempted to resume standard bag mask ventilation. Physiological deterioration began immediately. The mask seal failed, and airway resistance spiked drastically due to the trauma. Notice the telemetry collapse. The capnography waveform loses amplitude and becomes highly erratic, while oxygen saturation drops toward critical levels. At this moment, the focus moves entirely toward the cells. Securing the endotracheal tube is no longer the primary goal. A failure to intubate is a technical obstacle. A failure to oxygenate is an immediate threat to life. Persisting with laryngoscopy during this desaturation phase is the primary driver of hypoxic brain injury in the operating theater. Mastering this distinction allows a clinician to stop an unsuccessful attempt before it causes irreversible harm. The operator executed Plan B, immediately inserting a second-generation supraglottic airway as a rescue device. This device is deployed with a strict, limited objective: restore the capnogram and reverse hypoxia. It is not intended as the definitive surgical airway. The operating room team coordinated their roles and made an early call for experienced airway assistance. Calling for senior assistance is a proactive algorithmic clinical intervention. It is not a declaration of operator incompetence. The physiological recovery confirms the rescue maneuver. The capnography waveform stabilizes into a consistent, square rhythm, and the oxygen saturation recovers upward to baseline. Successful rescue oxygenation buys the team their most valuable asset: the cognitive time required to pause the surgery and formulate a safe, definitive plan. With oxygenation stabilized, we can evaluate the decision matrix on the algorithm flowchart. The options branch clearly: wake the patient, attempt intubation through the rescue device, or proceed with the surgery. Before acting on any branch, the team must confirm ventilation. Waveform capnography is the only objective proof of gas exchange. Visual chest rise and auscultation are entirely insufficient. Look at this strict definition. If those rescue maneuvers fail, the patient hits a final physiologic limit: cannot intubate, cannot oxygenate. A difficult glottic view does not define a SICO event. It is defined exclusively by the total failure of all oxygenation maneuvers. Hitting that precise limit dictates the immediate, unhesitating activation of front-of-neck surgical access protocols. Safe airway management requires knowing exactly when to abandon upper airway attempts to prevent terminal hypoxia. Utilizing the time bought by the rescue device, the team safely secured the definitive airway and allowed the surgical procedure to finish. But look at this timeline. Any patient who experiences a difficult induction enters an expanded, high-risk extubation window. Emergence from anesthesia compounds several risks at once, including residual sedation, fresh mucosal trauma, and reactive laryngeal edema. The difficult airway plan is not complete when the tube is secured. It ends only when the patient is safely breathing independently in the recovery unit. Clinical airway mastery is never about forcing the tube in at any cost. It is about relentlessly maintaining oxygenation while executing disciplined, algorithm-driven decisions.